Thank you, Beth, for that really wonderful introduction. Again, good morning, everybody. Thank you all for coming. Again, my name is Henley Wu. I'm one of the cardiovascular specialists that work here at Mount Sinai. And today, I'm going to be talking to you all about the mechanical circulatory support devices that we have in the Cath lab. Again, my name is Henley Wu. I don't have any financial relationships to disclose. So a little bit of an agenda, kind of what to expect in the next 10 to 15 minutes. The things I do want to go over is, number one, what exactly is mechanical circulatory support? Number two, I want to give an overview on some of the more common mechanical support devices that we have in the Cath lab. And number three, I want to touch upon what is going on in the future of mechanical circulatory support. So what is mechanical circulatory support? Well, the goal of mechanical support is always to restore our cardiac output in order to preserve our end organ function, right? Basically, we're talking about taking over the work of the heart. So for a lot of the devices that we're going to go over today, we're going to be talking about how that device can augment our cardiac output and also help our hemodynamics. And in the context of the Cath lab, and Dr. Sueyo had touched upon this a little bit. The etiology that we're more concerned about are your kind of post-MI, post-heart attack patients. So in addition to helping our cardiac output, we also have to talk about offloading the left ventricle. And the reason for that is a lot of the patients that we do that are post-STEMI, even after PCI, they have a lot of chest pain, signs and symptoms of shock. And what's going on here is that there is reperfusion injury. And the left ventricle is very stretched, there's volume overload, so your LV-EDP is high, and therefore your myocardial oxygen demand is also high. So if we can find a way to offload the LV, lower the volume, lower the LV-EDP, we're going to be promoting healing because we're going to be lowering that myocardial oxygen demand. So mechanical support is really critical in trying to optimize a balance between your oxygen supply and your oxygen consumption, because if we can do that, we allow time for the myocardium to recover. So how do we do this in the Cath lab? Well, we have a couple of choices. We have your intra-aortic balloon pump, we have our Impella devices, and finally we have extracorporeal membrane oxygenation, or Ecmo. And I kind of have a slide where we show all the devices here, and I have it kind of grouped up into two basic subcategories. We have your continuous and non-continuous flow devices, and also our intracorporeal and extracorporeal devices here. And of course, depending on where you work, kind of what their expertise is, and depending on which attending or physician you're working with, they all play factor into kind of which device you're going to be ending up using. So let's take a closer look at each one. So first off, we have the intra-aortic balloon pump. Again, like the name implies, this is a balloon. This is helium-filled, so this will make this your pneumatic or pulsatile device. This device will be inserted up the femoral artery retrograde via a 7.5 French system. And again, this is a relatively simple catheter. It's a balloon tip catheter, and this balloon will sit in the aorta. And during your cardiac cycle, it will inflate in diastole, and this will deflate during systole. And remember, in diastole is when our coronary arteries are going to be perfusing. So when we inflate in the aorta, not only is it going to stop blood from moving forward, it's actually going to push a lot of the blood backwards. So we are going to also increase our coronary blood flow. And this device is great because a lot of times we have STEMI patients that come in the Cath lab, and we find 3-vessel disease or left main disease, and we're still not sure whether the patient is going to go to complex PCI or CABG. We can elect to put a balloon pump in this patient because, again, it's going to help increase our coronary blood flow. Now, in systole, this is when the balloon will deflate. So when it deflates in the aorta, it's going to create a vacuum effect. It's going to pull a lot of blood forward, thereby afterload reducing your heart. And these 2 points are really the power of the balloon pump, right? Number one is going to be your augmentation of coronary blood flow, and number two will be your afterload reduction. So what are some contraindications for the balloon pump? Well, number one, we have aortic regurgitation, right? And as we know, aortic regurgitation is when your aortic valve is not fully closing during your cardiac cycle. So if we have a balloon pump and we expect the balloon pump to inflate and push blood back into our coronaries, if your aortic valve is open, instead we're pushing a lot of blood back into the ventricle, which is not what we want, and is not going to be helping our patient. And number two, more importantly, we also have contraindication of aortic dissection. Again, as we know, aortic dissection is a tear or injury to the lining of the aorta. if you imagine a balloon forcibly inflating or deflating in the aorta, not only can we cause the patient more pain, but we can also propagate that tear all the way down the aorta, and now you're left with a patient with not only a cardiac issue, you got a patient with a vascular issue as well. So again, contraindications of balloon pump, you have aortic dissection and your aortic regurgitation patients here. So next we'll talk a little bit about Impella. This is specifically the left-sided Impella, and we have a couple of different flavors for that. We got the Impella 2.5, the Impella CP, and the Impella 5.0. Your Impella is what's known as a microaxial flow pump, basically a suction catheter. And this is also inserted into the vasculature via the femoral artery. This is 14 French axis, so quite a lot bigger than your balloon pump. And again, this is a suction catheter, right? It's quite a long catheter, and this will sit across the aortic valve distally, where it will sit in the left ventricle, where there's an intake port and an output port in the aorta. So this will suck blood from the left ventricle and put it in the aorta. And this is great because it's replicating the natural blood flow of the heart. And because this catheter is also sitting in the left ventricle, you're also going to be lowering your LV-EDP and your overall mechanical work of the heart. And what's great about the Impella, at least from a Cath lab point of view, is it does two things for us. It provides hemodynamic support and myocardial protection. So we like to put this in patients that are going to undergo very complex PCIs. And also, I do want to note that because this catheter, you have to take into account the two intake port, the intake port and the outtake port. This is rather positional. If you imagine this catheter is too far distally into your left ventricle, you're really just taking blood from one chamber, putting it in the same chamber, really not doing anything with your patient. And the same thing applies if you have this catheter a little too proximally. You're really just putting blood from the aorta and back in the aorta. Contraindications for a device like this. Remember, we talked about this being 14 French, so peripheral artery disease is really going to be a contraindication here for Impella. You're going to have a really bad time trying to pass a catheter, let alone the sheath, through a patient with a peripheral artery disease like this. And remember, another contraindication we have would be severe aortic stenosis, because this catheter has to sit across the aortic valve. Again, if you don't have if you can't cross that catheter because of a dysfunctional valve, you're not going to be able to use that catheter. And more importantly, I want to point out another contraindication here would be LV thrombus. So remember, this is your suction catheter, right? If you put this catheter in your left ventricle where there's presence of thrombus, you could potentially disrupt what is something a little stable and send it systemically. And you could cause the patient all sorts of different issues. So again, contraindications for your Impella, peripheral artery disease, you have severe aortic stenosis, and LV thrombus. And you can't talk about left side Impella without talking about right side Impella. Left side Impella, like we stated, great for someone with LV dysfunction, right? But that's not going to be all our patients. Some of our patients come in with right-sided dysfunction as well, and that's really where our Impella RP shines. Our Impella RP is going to be your, again, microaxial flow pump is a suction device, right? This is going to be quite a bit bigger. This is 23 French, but this is sitting in your venous femoral vein or your venous axis because we're going to the right side of the heart. Catheter shaped differently, but the same principle applies. Shaped differently because we're sitting in different places. We're going to be sitting in your vena cava and putting blood back into your pulmonary artery to the pulmonary circuit. But key point is the Impella RP will be much more beneficial in patients with RV infarct versus a left-sided Impella. Contraindications, though, still very analogous to a left-sided Impella. Again, 23 French, quite a bit bigger, so peripheral artery disease, contraindication. We are also sitting across a valve in the Impella RP. This is the pulmonic valve, so somebody with pulmonic valve dysfunction, you really don't want to be using Impella. And also, very important, clots. If you have clot in your vena cava or your right atrium or ventricle, you could turn, again, what's potentially quite stable and put it into your pulmonary circulation and create pulmonary embolism. So again, that would be a contraindication. And finally, we have a little bit about Ecmo. So this is, again, Ecmo stands for Extracorporeal Membrane Oxygenation. This specifically is VA Ecmo, or venous arterial Ecmo. This is what's known as a continuous flow or centrifugal flow device. Because this is VA Ecmo, venous arterial, we're going to need access to our arterial axis and venous axis. And this is quite a bit bigger. This is 23 French and up, right? But what's great about the a VA Ecmo, this is kind of your full support. So this is going to take deoxygenated blood from the femoral vein, put it through the pump, put it through an oxygenator, and then put it back into your arterial circulation using the femoral artery. So again, full cardiac support. So obviously, because this is doing everything of the heart and the lungs, the people or patient population that's being even considered for ECMO would be very, very sick. Right. And again, you can't talk about VA ECMO, we'll talk about VV ECMO. So VV ECMO stands for venous, as the name implies. So this is pretty much a bedside lung bypass, right? Because this is going to be taking blood from your venous circulation, putting it through the oxygenator, and putting it back to the venous circulation. And why would you do something like this? Well, a lot of patients will have, their heart is working relatively okay, but they have really bad lungs. And more recently, we saw that a lot in COVID, where a lot of patients that have a severe ARDS, they just had a lot of fluid in their lungs, but their heart was fine. And we had a lot of patients being put on VV ECMO for that. So again, key takeaway for VV ECMO, used for patients, bad lungs, but the heart was okay. And I guess we have time to touch upon the future of mechanical circulatory support, and I guess a little bit about myself as well. Before joining the Cath lab about 6 years ago, I was a paramedic for the New York City 911 system for about 10 years. And in that time, I've worked my fair share of cardiac arrest, MIs, but I can really only count on like one hand the amount of patients that I remember resuscitating and then walking out of the hospital. Right? Because as we all know, working in medicine, after 20 minutes of resuscitation, the chance of a good neurological outcome for a patient is essentially zero, right? And we always have sayings like we heard door to balloon time, we have platinum 10 minutes, golden hour, et cetera. So it's all saying that time is really the most important piece of the puzzle in order to help patients. And that's something that a lot of hospitals, us included, if you listen to Greg's, we're all incorporating. And this is going to be coming in Ecmo Cpr or eCPR. So that means Ecmo Cpr is coming to the field. And what is the goal of Ecmo Cpr? Well, Ecmo Cpr, again, is to maintain end organ perfusion, but so a reversible cause for the cardiac arrest can be corrected, right? A lot of pilot programs, I talked about this last year, in US and Europe have begun, and most recently, I believe in Japan and Asia, they're doing studies that are having to do with Ecmo Cpr. And a couple of pictures here. I believe this is Paris Metro. We have the caption is cardiac surgeons. They're doing ECMO here with the whole EMS team. This is obviously the back of an ambulance. It's a lot more cramped than it looks. And keen-eyed observers, you can see portable ECMO and Impella on this patient. And this is new for this year. I think in Minnesota, they have started a dedicated ECMO truck, where if you see in the second picture in the back, it looks like they have a portable C-arm. So they're really, really doing this all the way in the field. We're bringing the Cath lab to them almost. Right, so lots of moving parts, right? So obviously it requires a lot of coordination with a lot of different services, pre-hospital, in-hospital, and but protocols are slowly coming out. We have on the left here kind of like a ideal timeline of what everything should happen. And currently it states that ECMO CPR protocols, about 20 minutes, you should be trying to initiate ECMO CPR. But again, a lot of infant studies, 8 to 29% increased survival rates. So everything is still up in the air, but what is very clear, at least to me, is that ECMO CPR is a very viable form of resuscitation. So I guess in conclusion, I know we went through a lot very quickly, but I hope I gave everybody a nice overview of the different mechanical support devices that we have in the Cath lab. And most importantly, I hope I could also tickle your interest in what is really happening in this kind of developing field. All right, again, my name is Henley Wu. Please, if you guys have any questions or comments, please email me. I'm usually pretty good about getting back to people. All right, thank you so much, guys.